So with no further ado, I'll introduce our keynote speaker, Dr. Goldfrank, chairman of our department here at Bellevue.
So it's a pleasure to have so many of you here today. I think I started in emergency medicine 40 years ago. Things didn't look like the images we have there, but initially I saw Tony Corsieri in the back of the room, and so that probably I was the first physician that taught him how to do orthostatic changes in the South Bronx. And probably we didn't have the evidence, but we were looking for different problems. So that the number of people in the front row today are identical to the number of people, almost, who were residents in emergency medicine in 1973 when I started. There were very, very few. When I was, I guess, the chairman of emergency medicine in the South Bronx, there weren't any other faculty, nor were there any residents, nor were there any students, so it was pretty easy. We were the staff. But we've come a long way. The big issues are what do we really do this job for? What is it really all about? And that I was taught, long before I was taught much about medicine, I was taught about the principles of medicine, or the societal principles. And certainly one of my mentors was Virchow. The concept of what medicine is a social science, and politics is really nothing more than medicine on this grand scale. And the things that we've been through to develop the process really related to deciding why we come to work, what the problems are. The job we face every single day is really looking at why people are there, and then trying to design the medicine that we have to do to meet the demands of our society. Makes it easy for those of us in New York City. The idea that emergency medicine represents all people under any circumstance coming for need. The principles are clear. It wasn't so clear in the beginning. And the beginning, for me, was in Baltimore, when you had a choice of which door you'd go through each day when you went to study medicine, and where the patients went. And so the civil rights activities of the 60s, 70s, really led to what emergency medicine was going to become. Because prior to that time, most people didn't have access. And it's just as Johnson was working on Civil Rights Act, Medicaid and Medicare were developing. And people who never had access, there was no right, and EMTALA was a number of years still to come, there were no options. In many ways, although the last statement says the basis that separate is inherently unequal, obviously we're in a private hospital here. Down the street we have a public hospital. Further on down we have a Veterans Administration hospital, governmental hospital. And the question is, can we get to a standard where we have equity for all human beings, and how do we do it? And it doesn't necessarily mean that the care, obviously, for those of you who've had this New York experience or any place else, there are clearly tremendous advantages to many of the hospitals. The advantages are different, the disadvantages are different, and how we build a system that has all those things will probably come out of how well we do emergency medicine. George Orwell, who you know for 1984, talked about an experience. This was a picture of Bellevue. It's actually an identical picture we use in our discussion for the work we're doing in Ghana these days, that Orwell noticed when he had tuberculosis and was in Paris in the 30s, that during the first hour in the hospital, I had a whole series of different and contradictory treatments, but this was misleading. For in general, you got very little treatment at all, either good or bad, unless you were ill in some interesting and instructive way. And that's a battle we've got to confront continuously, because everyone's coming for help. And you saw in the eloquent description of that patient, or that group of patients who had very minor problem from the life and death point of view, who happened to have a first trimester threatened abortion or bleeding, and we weren't sure, as the description went through in the discussion this morning. We've got to do better for everyone who comes through the door, and there's an awful lot to do that is exceptionally high yield from seeing people. The idea that hospitals are constructed, how is it being done? What do the poor really get? Why do the rich give money? Lots of philosophers have thought about the integrity of our healthcare system, and it's a battle that goes on continuously that we as activists in our environment have an essential role in confronting. So I'd like to look at a case. Everyone chooses a case, and I won't be as brief because it's a case that revolutionized our world in New York City and really filled this room with emergency residents and physicians. And Holmes said to Watson, "At least I have a grip of the essential facts of the case. I shall enumerate them to you, for nothing clears up a case so much as stating it to another person." We use that model almost always in the emergency department. We talk, we get a vignette, we use some of the information, maybe not adequate amount of information, but we've got to have a foundation for communication. Libby Zion died following a visit to an emergency department in a hospital. And Dan Lugassi presented the concepts that we've evolved over these last 30 years since that happened. But the politics and the social policy and the evolution of our approach to medicine was very dramatic. It became so dramatic that by a decade after she had died, she became a critical part of a question and this was taken for, I guess the questions could be shared then without question of ethics. We all know the answer to this now, and he mentioned that in his discussion this morning. But a young woman, 1984, 30 years ago, presenting to an emergency department. She happened to have a mother and father who were both journalists, very politically involved. She went to the hospital. Her complaints were agitation, fever, chills, myalgia. She was sick. She was a little histrionic. The examination done by a medical resident, and that time we were just going through the evolution of categorizing emergency departments in the city of New York, the standards you have to have, and who had to be there to receive ambulances. And so that people could walk in, but the question of ambulances, someone with agitation and a high fever might not have been appropriate. Ambulances weren't delivered to all hospitals who were not categorized by what we call the 911 system. Medical history had a number of things. Theoretically, she had some psychiatric problems. She had a tooth extraction. She had an earache. She was on phenelzine, oxycodone, and erythromycin. The emergency department admission temperature was 39.7 degrees centigrade. She had orthostatic pulse and blood pressure changes were told in the chart. The family wanted the private physician to come to the hospital to help out. The father and mother weren't satisfied that a resident, there were no supervising attendings in most emergency departments in the city, certainly not in those you didn't have to have attendings if you didn't have ambulances, and you didn't have attendings if you didn't have emergency medicine training program. The resident made a diagnosis of viral syndrome with hysterical symptoms, got some blood cultures, and prescribed acetaminophen for fever and meperidine for agitation and shivering. That was done, I think, because probably the residents there often did work in Memorial Sloan Kettering, and lots of patients were getting amphotericin, and so that was a thought that was the shivering might be associated with a reaction that could respond. The young woman was admitted to the medical service under the care of a medical intern and a resident. The intern was called when the patient became restless and disoriented. Rather than evaluate the patient over the telephone, physical restraints were employed and haloperidol was given. The patient became more agitated and febrile, and a cooling blanket was placed on the patient. 4.5 hours after admission, the patient expired with approximately 109 temperature, at least in the axilla. We could debate for some time the issue of what the etiology is, whether it's agitated delirium, how do we treat that, hyperthermia, which Dan discussed, Demerol or meperidine phenelzine reaction, restraints, intramuscular injections, how was that useful, how do we use restraints, what's the role of an ICU in someone who's febrile and has life-threatening hyperthermia, what about the serotonin syndrome or cocaine or MDMA, which was in vogue in the city at that time, then those drugs, oxycodone, phenelzine, and chlortrimeton. Could they have all played a role? Sure, any of these would be interesting to discuss, but none of that I'll spend much time on today, other than the implications for these. So this case went from the family to the newspaper and ultimately to the Robert Morgenthau, who was then the district attorney. The fellow on the right happens to be my neighbor in Ossining, New York. So when the case was brought to him, he came to visit me. Rarely, I've come here for 30 years, always take the train. But for the 3 months or 4 months that the grand jury was in session and he was working in this case, he drove me to work every single day. And we talked about this and participated in the evolution of what I think was critical for the development of emergency medicine and for a number of changes we face. In that era, if we were having a discussion of emergency medicine in this medical school, and I was already there here a number of years, there would be a very small number of people, probably there'd be more than in the first row, but not many more. What was the role of emergency medicine? Did it really need to exist? The battle in the medical schools across the country was probably those medical schools that we called a paper that some of us in emergency medicine wrote, really focused. John Gallagher worked hard on this. We were trying to define a term called academicity. The higher the academicity of the institution, the lower the probability of having an emergency medicine resident. This was really just not going to be accepted as part of what our role was in medicine. What about university support? There were more of us faced a series of deans who would have said emergency medicine would occur here over my dead body. And that was a typical discussion. What about the public hospitals versus the university? And many of the public hospitals were developing the remarkable programs that were essential for survival to get quality people in for these masses of individuals who had been given rights to access to care. Where the ambulances went, there had to be people who were going to do it, who was going to provide the care. And what was the purpose? What would we really do? And Picasso often helps us in these issues in the sense that any of us, if I were someone in training in medical school looking at this problem that was emergency medicine, and I were a person working in the emergency department, we see distinctly different things. And with the vision of entire society, it's those visions that were important for us to develop in this grand jury hearing and ultimately some discussions that occurred thereafter. So what happened after this extensive analysis by the grand jury, the hearings, was that we worked very carefully with them, and that the appendices to the Supreme Court decision were that emergency department standards, the 911 receiving standards that were created in this city by an administrator and a nursing leader, administrative leader, and physician leader of every emergency department in the city. There were those days, I think, about 60 hospitals that wished to receive ambulances. They worked together to create the standards they thought would be the future of emergency medicine. And it was worked out with probably everyone you know in your departments who has any experience in emergency medicine in New York City over a period of the last 20 or 30 years. But this was done over following grants that occurred in this city and across the country during the Nixon administration in the 70s that got all of us beginning in that era in emergency medicine started with funds and support and focus of regionalization, systems of transport, ambulance standards, physician's assistant, paramedics, and physicians itself. Second was proposed emergency department standards for the state of New York. And those standards evolved out of the development across the country in emergency medicine, really led to the understanding of the number of people you would need to staff emergency departments across the city. In many ways, the goals were a little bit like the evolution of what Martin Luther King had said, is that many of us talked about, well, that I had a dream that we'd like everyone who comes into an emergency department comatose or badly injured to wake up and see an emergency physician looking over them, trying to solve a problem. And in those days, there were merely a handful of people who were doing emergency medicine, who were trained in emergency medicine, were committed to the field. So the issue was convincing people of what had to be done. And the people, many people who came to give testimony to the grand jury, commented on the tremendous deficits in service to people in our city and probably across the country. And the last, which you can recognize in a number of the things that you deal with day in and day out, is how should people be treated who are agitated and uncontrolled? Where should sedation occur? What kind of sedation should occur? Should restraints be placed? Were cooling blankets adequate? What kind of supervision did people need? When should someone who had an agitated delirium be in an intensive care unit versus on a floor? So it really thought about blending what kind of doctors and what kind of service could be done to people who had such critical problems. The Supreme Court said at least to allow people to receive ambulances in our city, there had to be at least an individual who had 3 years of training in emergency medicine. They said that contemporaneous in-person supervision by an attending was essential to run an emergency department. It was a big step forward. Prior to that, they were merely moonlighters or people who they could have had a lot of training, but not little or none of it would have been in emergency medicine. There had to be standards for the use of restraints. There had to be a limit on the number of consecutive hours. We'll talk about that at length. And we said, this was 30 years ago, that there had to be computerized drug ordering because it was certainly suggested that the combination of the phenelzine and the meperidine might have exacerbated her already elevated temperature, and that lethal drug interaction might have been a serotonin syndrome that had been missed. It could have been that she had taken MDMA and that she was exceedingly agitated, but there had to be an understanding of what drug reactions were and drug interactions. And if there had to be a system that gave access to people, this became one of the large, substantial financial and political pushes for the development of the New York City Poison Center and the others across the country. So the grand jury statement, their conclusion was, we have made these recommendations with the hope that future hospital patients will receive more experienced professional medical care than did this unfortunate young woman. And subsequently, also one of the famous professors from Einstein, probably a good friend of Tony Corsieri, was Bert Bell became the chair of a commission established by Andrew Cuomo's father, Mario Cuomo, who was the governor then. And he had a remarkable commissioner of health, a fellow named David Axelrod, courageous leader, much like Coop in working on the integrity of care for people with AIDS in our city. And he brought together about 8 people in healthcare, hospital administrators, internists, surgeon, 1 or 2 emergency physicians, of which I was one, and a couple of other people from ambulatory care and hospital executives. And we worked for 2 years and listened to everyone in the country about the standards we were considering establishing that followed a good bit of that which the grand jury had worked on. Robert Petersdorf, better known for fevers of unknown origin, and the president of the American Association of Medical Colleges, and essentially every leadership role in American medicine, led the opposition in 1985 when he stated, continuity of care, it's better to have a tired doctor who knew the case than a rested one who only reads the chart. Or shorter hours lead to lost experience. Medicine is a calling, not a job. One's patience over other considerations, fixed schedules equals shift mentality. So things that we disagreed with, some things that we might agree with, some concept we'd look at, but the big issues had to be thought about in other areas as well. So what about education versus service? What was our job going to be for residents in hospitals? What about the fatigue and the sleepless nights, and could people think as well? What are the human factors to do a good job and to be a resident, to get a good education? What about the loss of creativity and the cognitive skills? How would we measure these issues? Was there a question? People have always said that medical students start out doing such a wonderful job, and by the time they've wound up in these seats or they become faculty, they don't have that humanity and the ethics and the high standards. Is that true? Is it essential? What about the loss of altruism? What about our empathy? So a host of issues that had to be confronted, and many people came to speak about from Britain and New Zealand already working on hours, and the other issues of psychologists and what did make a good doctor, and could we really train good doctors at this point? The standards were set that limited resident hours to 80 hours a week, no more than 24 hours consecutively in the hospital, at least 12 hours off per week, a maximum of 12 hours in the ED. Those were the issues about hours. But one of the big issues that was emphasized extensively by us was really that all this care had to be done with contemporaneous supervision by faculty. And that was established almost immediately by emergency medicine. It was not established and was fought extensively elsewhere. And this is what occurred. Sidney Zion wrote a piece in the New York Times in 1989, and David Axelrod's resignation was called for by the New York State Medical Society. The Hospital Association of New York brought a suit to enjoin him from following through on these acts. So the hostility was immense. I wouldn't emphasize that at least the dean that I worked with told me categorically that I was not permitted to go and participate in this work with David Axelrod, that everyone was going to resist this. So you can imagine my relationships didn't get enhanced. through that experience. The debate in emergency medicine was really nicely phrased by Bob Knopp in the Annals of Emergency Medicine. He was from that point from, I guess, Regents or Hennepin or Fresno. He did most of that type of work at public hospitals for a great part of his life. Residents without supervision and education was on the one end, attendings providing continuous supervision was on the other. How would we decide that? Some hospitals had a situation where the faculty member was at a distance, was at home, could be called in. Some people stayed in another room, didn't participate. And this battle was going on, and many of the people across the country said, you know, this will destroy emergency medicine if the faculty have to work at nights. And maybe it's a good time for residents to learn and work a little bit on their own, and it's safe enough since there are not that many patients. And ultimately, we in emergency medicine decided on the bottom line, because a patient only has one life to give, and people come in at any time, and they're entitled to the best possible care at any time, day or night. And this changed where we were going, and it allowed us to stand up with integrity throughout the community about what our goals were. This hierarchical system of graded authority and responsibility was vital, the chain of supervision, but the problem that existed in that era, and that maybe exists sometimes today, is that the discipline we don't want to disturb. You'd like to let the person who has right on the front line do most of the work and ignore that person, and that's just not acceptable. And it's a sense that a redistribution of responsibility was essential, how to do this kind of teaching correctly and maintain our integrity. So from this building, a crisis occurred in that we at Bellevue couldn't develop an emergency medicine residency because, as with many of the academic institutions, the dean here didn't believe in having emergency medicine and felt that it was going to destroy the quality of medical education. As it happened, a reporter from the New York Times, who personally I think is a great guy, and I've read a number of his books, and he does a tremendous photography now. He and I spoke almost weekly for several years, and he followed the events from an academic reporter's perspective, and he talked to lots of people and went to see things, but he didn't talk to a number of us. He didn't come to meet personally. He didn't want to personalize the issues. What happened is that since I couldn't make friends in the academic community, I made friends in the community board and the people who worked around the hospital at Bellevue. And I went to their community board meetings on a monthly basis and talked to the people of the community and explained that the goal we had in emergency medicine was to have someone who could not only help someone with chest pain, but a laceration of the hand, and that you could have one person who could think about those things from a very broad perspective. And that I said that unless you got emergency physicians, you weren't going to be able to have a capacity to deal with 100,000 patients who are coming through the door effectively, because it wasn't good enough to have an internist look at your lacerated hand, or an internal medicine resident, so to speak, or a surgeon look at your chest pain. It wasn't going to be as effective if we could create a new specialty of people. And so ultimately the community board made a statement that they were not going to permit New York University medical students to work at Bellevue Hospital unless this was resolved. That was a real crisis because the students have been going for 150 years, and it was going to cause, as one recognized with the flood, if you don't have a place for medical students to be trained, it makes a great difficulty for everyone. So it led to a resolution. And at that point, all of our faculty were not appointed as faculty, and their rights were very limited. And the process had to evolve for me to feel we could train residents and we could train faculty and we could maintain faculty, because people, by this time, in the late 1980s, people were going to programs and succeeding very nicely elsewhere. So Petersdorf, by 1991, had said, my wish would be that the profession had been more perceptive and recognized the issue and making the appropriate changes. So changes had occurred there. And this debate over patient needs, maximal patient benefits, and minimal risk for patients, much as we've heard this morning, maximal control of the situation with minimal interference. How do you do that? How do you achieve effective education and supervision? And the nicely phrased in Paul Farmer's book, the book about Paul Farmer, was, you can't sympathize with the staff too much or you risk not sympathizing with the patients. We know why we're here, to care for the patients. And we know that we want people to have a reasonable amount of time to come to a hospital and work and devote one's time to the care of a human being without risk that that patient suffers in any way. So to do that in an emergency department, we felt that over time, one had to be very careful in limiting the amount of time one spent in the emergency department so that kind of excellence could be achieved. To make that work, you had to carve out time so that residents could do the things that were essential to grow and develop and to get the kind of intellectual strength that's necessary to accomplish excellence on a day-to-day basis. And so that liberating residents from clinical time and making sure that they could be at conferences such as this or at research meetings or whatever, morning reports, so that there could be an intellectual growth and development, and that there was enough opportunity to work with a sophisticated faculty, so that people could develop their career interests and they could devote time to the study of the medical literature and preserve the professionalism and take on the responsibility that I think we all feel that we've got to find the capacity to look at the human beings who come to the emergency department and find what's critically wrong, what's the lesion in the public health system that has to be resolved, what's the human project that you'd like to take on as a resident or a faculty member so that we can solve societal problems and not just observe them. And I think this is going back to Virchow again, is really to look at the community. What do we have to solve there? Much like Semmelweis did in making sure that the Clorox eliminated the bacteria and didn't transmit childbirth fever, and making sure that, as Virchow did, that scrub typhus wasn't just something they observed, but that they corrected in society. And so that we began to work in this era of making sure we had standards for ambulances, the supervision, specified receiving hospitals. They couldn't just go anywhere. Things had to change. They had to be in an organized fashion. But the ongoing foment in our city was really over this hospital emergency. How would you get the hospitals to work? How would you integrate them? There was such a battle over the development of emergency medicine that many places didn't have it, or it wasn't good enough, or didn't get enough support if it did exist. And how to get an understanding in the community of what an emergency medicine did, and how to assure that we could really understand this process, and that EMTALA began to transform the hospital's responsibility. And it became overwhelming for some hospitals. And as this PhD thesis by Sandra Updike suggests, the de-differentiation of hospitals in the 20th century was really over those that were going to focus on the needs of anyone who could come in the door versus those that would focus on those patients who were more interesting, as Orwell suggested, or brought more financial recompense to the institution. And so that emergency medicine and the battle over that, which we did, really had to be, it was a philosophic, existential issue. We had to fight so people could understand what we were doing, otherwise we weren't going to survive. And in many ways, the problems mounted, as you recognize. People talk about 50 or 60 people waiting in the emergency department. In this era, as we began in the early 90s, and late 80s and early 90s, when every bed was filled with someone with AIDS or tuberculosis, resistant disease was endemic, and there wasn't service and people were concerned about how to function, the very meaning of what we were doing continued to battle. And then these things, again, by Howard French, about this new specialty, this fierce debate in the hospital about what the future of care would be and what roles we would all play. In many ways, this image at the Modern is really these two nuns, and this having as much time understanding Matisse's dance image as deans were having understanding what emergency medicine was doing. There was no capacity to grasp that which we were trying to accomplish. This was a critical battle, and in many places, you saw Peter Rosen in one of the images. Peter Rosen was working in Denver, much like a place like Bellevue, and in Denver General, they didn't have faculty appointments either. In Denver, they had their faculty appointments from the University of Oregon in Health Sciences. And that was arranged because of our good friend Jerris Hedges, who was running the department there, and organized that that could be done. So our people didn't have appointments, and this was an on-off switch that was resolved in many places by a political act, wherever it was in our country. This is an article that's worth reading, and this is a current article, but this really talks about how people looked at emergency medicine. This is a guy named Fred, that's his last name, in Texas Heart Journal, quite recently. He was looking back on his career as a Johns Hopkins trained physician, great educator, who looked at this issue. The structure and function of emergency rooms around the country began to change. In 1989, emergency medicine became an independent specialty. As a consequence, the supervision of patient care in ERs switched from surgeons. Remember, those were probably interns in surgery. Surgeons and interns to specialists in emergency medicine. Admissions increased, forcing premature patient turnover, et cetera. Essentially the downfall of the hospital system. Well, when you look at it, this kind of analysis is what others were living at. What really was it going to be like? People didn't want to provide care for the individual who came through the door. Why were they there? What was needed? Who was going to get ambulatory care? Who should be admitted to the hospital? It was always a fight to get people admitted to the hospital in those days. That type of issue has changed as we've had a more integrated and collaborative effort. Another piece about large hospitals have less need for emergency medicine training. Trying to find a way to say it could be good for rural or it could be good for poor areas, but not for big cities. Some of the work from that Libby Zion case and the Bell Commission led to, discussed at length, into Air is Human from the Institute of Medicine. Ultimately, we had at the Institute of Medicine a piece on poison prevention and control systems. So critical follow-up. Again, Howard French, this crisis in hospitals. Resist quick or inexpensive solutions. General Hospital, New York City style. These were the halls were filled, the problems were unsolved, the collaboration was low. So that several of us who were presidents or just past presidents of the Society for Academic Emergency Medicine went to the Macy Foundation, Louis Ling in particular and I. Macy Foundation was the Upper East Side, and we presented that, a model for the role of emergency medicine in the future of American medical care. And that was accepted and really led to a wonderful progress in design for those of us in emergency medicine at that time. First thing that there should be, the United States Public Health Service should comment that as a new goal, that access to high quality emergency medical care was essential. In those things you hear about, Public Health 2000, 2010, 2020, emergency medicine had never been found in any of those documents. It became a key part of that document. COGME, Council on Graduate Medical Education, should ensure the number of residency positions in emergency medicine was not reduced. Just as we were developing, there was going to be an approach to decreasing the number of positions. That was accomplished as well. The Joint Commission should revise the classification of emergency departments. Classification should reflect the level of care available. In other words, you could have some emergency departments that had a rotating dermatologist on as the sole provider. You didn't provide people access. The name didn't mean anything. There had to be standards elsewhere in the country that we were using in New York. In addition, the classification of EDs should establish minimum qualifications. Special attention for moonlighting, same concept. We wrote a piece in academic emergency medicine that really emphasized credentialed emergency physicians 24 hours a day. In doing that, and that really came out of the state health department process, the goal was, and New York followed almost immediately, to say, if we were to get all these physicians, the state health department said, you're going to have to train emergency physicians, and you're going to have education in emergency medicine in every medical school in our state. And we have to guarantee that those programs developed expeditiously. This was the next point, that every medical student had acquired appropriate knowledge and skills to care for emergency patients. It's taken us here a number of years. Many of you in other programs have had earlier experiences, but now large numbers of medical students do their selectives and electives in emergency medicine. Not so that everyone will be an emergency physician, but so that everyone will understand what goes on in the village common, everyone will know how to communicate better, and we can make it a better world for the patients. Then ACEP and SAM should rapidly advance their efforts with regard to research in emergency medicine, and I think that all of these 5 things occurred very rapidly. And the last, this is that the deans and faculty of all licensed medical schools should establish in their schools appropriately stated and supported academic departments. And probably today almost all medical schools train medical students in emergency medicine, and almost all programs either have established or near establishing academic departments of emergency medicine, which obviously makes a design plan for the future. Increased gap between EM and other specialties, to sort of skip over that, it showed that even a decade later, 15 years later, surgery and internal medicine had not changed the hours and not had the consecutive hours decreased, and that's working on now. But the biggest issue, we really never emphasized the issue of hours. That was stated that we did not feel that that was productive, but we felt that supervision was essential. And as you recognize in many departments, the supervision has never been accomplished. And I think that's what we felt was graduate medical education, that there had to be the kind of supervision that had to be contemporaneous, and we had to find out through the creativity of the young faculty exactly how to work with residents so they didn't feel deprived, but they felt enriched by the experience of supervision. And how did we assure that patient safety and quality in this delicate balance, all the things that we ask a young physician to do, we ask people to be, how would we develop that effectively in our environment? And we search for that every single day as we work. And the ending of Sidney Zion's editorial, on the other hand, if we wake up and make our voices heard, one day they'll teach in medical schools around the world. Once upon a time in America, the finest hospitals were run by the least experienced and most overworked apprentice doctors, until one Sunday night in New York, a redheaded girl named Libby Zion. So, you know, at the end of the story, the people who've done this, and this is emergency physicians, medical toxicologists, look at it. We've run a program in medical toxicology here for 30 years. They fill every spot in America. And you can do that for lots of us in emergency medicine and medical toxicology. You can do lots of that for many of the things that we're developing, filling the medical schools, filling all of the sites in our social and political and scientific structures in our country. So it's great accomplishments. These 3 recent reports from the Institute of Medicine, all available to you at this www.iom.edu. Really emergency care for children, emergency medical services, emergency hospital-based care. All of them have the problems and the design for the future of our specialty. Lots of great collaboration, a total change in perspective, shared efforts, and lots of unbiased people getting together to try to solve problems. Recognizing, much as Virchow once again said, that you know, medicine will become the common good of all. It will cease to be medicine. It will be absorbed into the general body of knowledge, which is identifiable with power. I think that emergency medicine can do almost anything. We're asked to do almost anything. The question is how to do it by integrating effectively across, let's say, emergency response processes, the medical care system, the public health system. There aren't any limits. So we're often doctors without borders. The borders aren't defined by what we would like to do. They're defined by the needs of the patients for whom we come to work each day. And how we develop this process, how we work on it, becomes where you can be creative. Also, about 20 years ago, in academic emergency medicine as an SAM project, we worked on a public health approach to emergency medicine, preparing for the 21st century. It's certainly where you will be in the things you're asked to do and how we develop it. And there are no limits to what you can do, and there are no limits to what you'll be asked to do. And that my sense has always been that emergency medicine, the better we get public health, the smaller emergency medicine becomes. And the things that you'd like other people to do well will be established if we can accomplish an understanding of the links and how we get people into primary care, how we reduce things. We finally had a response from the police department about collisions the other day, that they're going to investigate the people more rapidly. And I don't think there's every police commissioner I've ever known and every police meeting I've gone to talk about these things, we said, don't call them accidents. Try to get involved and make a change. Just as the CDC has switched to prevention, they call them collisions. There's almost nothing that we see that can't be looked at as a problem we couldn't correct. And it's if we all got together and worked on those corrective actions, we would have a different society to deal with. The issues of where we fit into the process, the public hospital, to come back to that perspective, there's no question that by moving between a public and private institution, you see these different transitions in our society. Here we may face the advanced degenerative phases of life. There we may still face the epidemics. When we switch back and forth and move to Africa or we move elsewhere in the developing world, you see problems that we haven't seen for some time. We need to learn how to solve these issues, how to create what the safety net does for people. It doesn't have to be in a hospital if it's done better, but to think these things through. And this 4 chairs in our institution wrote this article, really looking at the role of public hospital in American medicine. I think exceptionally important for us and things that we believe very strongly in. And ultimately, many of the things we do, the battles we've had to resolve the role of emergency medicine in medical schools, sometimes makes it easier to think about the things we do are so important with regard to public health and public policy that we might very well fit better into that model at times. So I think it's a pleasure to be with you. It's obviously a great accomplishment for us to fill a room with emergency medicine residents and students and faculty to see where we've been to some extent and where we're going. And I think the speeches today have been great and the vision is great. And it's up to you who are in the room to assure that we don't forget how fragile the care is for the people we serve. And particularly, it's up to us to make a big difference. So thank you very much.